All right, I have 1:33 on my clock Eastern, so we'll go ahead and get started. Thank you everybody for being here for part 2 of Telehealth, COVID-19 and intimate partner violence, increasing safety for people surviving abuse. Next slide. I want to give again thanks to the MTAP partners for everyone. I hope that you know these groups and the individuals that make up these groups. If not, definitely would recommend getting to know some of these partners, and hopefully we'll have some directory or something where you all can find these individuals. Few housekeeping guidelines. So we do all ask that you either mute yourself when you're not talking, but feel free to unmute yourself, if you have a comment or question or you want to engage with us. We do ask that you use the chat box often, frequently. That's kind of where we can make sure everybody's following along and, addressing other questions or concerns. Feel free to reach out to Alice, Rebecca, or myself via the direct message if you like as well. And again, this webinar will be recorded, so be mindful of what you're sharing. And again, thanks for joining. So this material will be on our website at maternalhealthlearning.org. There's other useful content in there as well, so definitely recommend everyone checking that out. And for those who attended part 1 and part 2, there will be certificates of attendance that we'll be providing, and we are looking at being able to provide credits. So that's something that could happen. So thank you for attending part 1 and part 2. And we'll be using your email addresses that you use to sign in for that. You'll also be receiving a survey that Alice will talk about a little later that will ask for you all to fill out as well, but that will be anonymous. Okay, we're gonna go right to Miss Rebecca.
Well, thank you. And thank you for coming today. I hope many of you were able to attend the last training because, as you know, we were talking about self-care, but I do know that there's some new folks in the room, so I'm just going to go ahead and introduce myself one more time. So my name is Rebecca Levinson, and I live in Berkeley, California, and I care deeply about the issue of maternity care and equity, and I'm super excited to be with you and share some of the learnings. Just by way of background, years ago, I was a director for 3 public health clinics. We did full spectrum primary care, but we did a lot of maternal care, and I was a perinatal case manager. So moving forward, when I got hired to work at Futures Without Violence to look at the intersections between intimate partner violence, sorry, I'm gonna move myself forward for 1 minute, between intimate partner violence and maternal health and reproductive health, I had the opportunity to go do site visits all across the country. So I've worked with maternal health providers in every single state in this country, in many states, many times over, with the exception of one state, Delaware. I'm hoping that when Joe Biden, our president, is a little less busy, I'll have an opportunity to go visit his beautiful state. But in any case, this is all very near and dear to my heart. And the work of Futures Without Violence, if you don't know about us, we are the U.S. Department of Health and Human Services National Resource Center on health and domestic violence for the entire country. So we look at the latest research. We look at innovation. We look at model policies and practices. And we work with domestic violence advocates as well, so that all of our work is really informed and created by and for the folks that we are serving. So you'll hear yourself in some way, shape, or form somewhere in this talk, because some nurse, some doctor, some social worker, some home visitor shared something along the way that made it into one of the slides, because of course this really is all for you. To go back for one step, I just wanted to remind us of the learning objectives for today. I'm going to describe evolving practices and challenges around virtual care and intimate partner violence. And I know that you all are in the middle of it. So I'm, again, just reflecting back your voices and then talking about some national strategies that we've seen in action, real time, on the ground work to support you in this important work. And then I'm going to describe our evidence-based cues intervention to address intimate partner violence, and we've adapted that for virtual visits. So you're going to walk away with actual tools that you can use and apply with the next patient or client you're serving. The other thing I want to acknowledge, because we always know that there are survivors everywhere we go, right? So 1 in 4 women are going to experience intimate partner violence in their lifetime, 1 in 9 men. And I think that we want to recognize that when we talk about these things, potentially stories get stirred up. So if you've carried a client or patient in your heart and the story that I tell is really close to that and you get triggered, I want you to take care of yourself. This is being recorded. You can always go back and listen. So please, leave the call, go outside, get fresh air. If you would like to talk to someone or chat with someone in real time, because I know that in addition to having vicarious and secondary trauma, which is what we talked about 2 days ago, I also know that any number of you have personally been impacted by domestic violence, whether you grew up in a home with it or you've experienced it yourself. So I want to say, if you've never called the hotline, the folks there are the warmest, kindest, nicest. There's a language line that, they serve over 179 different languages. Half the staff are Spanish speaking. So I just really wanted to encourage you all, if something comes up along the way, take care of yourself, because the rest of it's going to be there for later. So I am going to take a collective moment to stop. So I'm just going to ask everybody, if you wouldn't mind, just put down your phone. And I want to do just a really quick little exercise to ground us, right? So it's COVID. It's been hard. I think the election cycle was really hard. I think there's just been a hard time. And so let's all take a second and get a little bit grounded together. I'm going to ask you to take one hand and rub it up slowly against the other hand so you can feel all the ridges on your hand. Just take a second to really notice that and go back and forth. And if you want to, you can close your eyes, maybe take a deep breath. Okay, let's get started. And just also as a reminder from our last talk 2 days ago, we talked about strategies to help if you get triggered. And you remember that taking deep breaths, holding them for a count of 3, blowing them out slowly can be helpful. We also talked about grounding. This is a grounding exercise. Uncrossing your legs and moving your feet forward in your chair. So you're really sitting forward in your chair, so the balls of your feet and the heels of your feet touch the ground. Can be great. Self-talk. I got this, I got this, I got this. Some people use a prayer. That can be a strategy to soothe your soul, and then imagery as well. So I just really want folks to know that there's a lot of capacity. Oh, thank you for that, Alice. Thank you for putting the number in the chat. So my question is, what questions were you hoping to get answered today? I'm certainly got a lot of content for you, but I did want to know if there was something pressing that anybody was hoping to get, or a concern. And as Wesley said, you can raise your hand and you can open up your mic if you want to. You can talk in the chat. But I did want to make sure that if there was something pressing, that we had an opportunity to talk about it. And I know sometimes when people are typing, it takes a while for things to populate the chat. So I'm okay hanging out for just a minute. Any questions? Or maybe you're all on the same page and you're just looking to learn. Well, if you think of questions as I go forward, please do put them in the chat or feel free to raise your hand. So what is domestic violence? What does it include? I think many of us think about physical violence first. And certainly you all know as providers, sexual violence can be absolutely a part and parcel of what your clients or patients are experiencing. What we do at Futures is we think a lot about the public health definition of what is intimate partner violence. And the public health definition is looking at how does it impact your health? Not necessarily what could be what's a criminal offense, so, you know, using a weapon, et cetera, we're really thinking about how does it affect your health overall. And, you know, so we know that emotional abuse, the words that people use, have a huge impact on their health and well-being. So if you're told you're worthless every day, it's hard to override that narrative, especially if you're thinking about isolation and COVID and not having access to people who are loving and kind if you're in an unhealthy relationship. We know economic power and control shows up all the time. In fact, it can be the reason why a client couldn't get to you for services pre-COVID or during COVID. So we know that power and control is a really important element to be thinking about. So it's essentially domestic violence, intimate partner violence. I'm going to be using those terms interchangeably based on the data and recognizing that I have all comers to our webinar today. So some folks use intimate partner violence, some folks use domestic violence. But what we're really talking about is a pattern, a person in a relationship who uses a pattern of methods and tactics to maintain that power and control. It's not a one-off, it's not a one-time incident. Abusers can use jealousy, social status, mental health, etc., as I mentioned earlier. How common is domestic violence? We know that 1 in 3 American women, sorry, this is the updates from the CDC. This was a NSVIS data. 1 in 3 American women will experience intimate partner in their lifetime. And there's a very high percentage among mothers. And that's sort of the big takeaway for all of you. We know that intimate partner violence cuts across all race, class, sexual orientation, gender identity, but some groups are more at risk. We know that, for example, transgender folks are, I think it's 36% of them will experience intimate partner violence, and I think it's as high as 52% will experience sexual violence in their lifetime. I'm going to share a little home visitation data because this is working with you know, folks who typically are at 200% of the poverty level or 150% of the poverty level or below. And I know many of you are working in those populations. What we know is that 17% of those women reported past year physical or psychological abuse. We know that when we look at low income, predominantly single women, the rates go up to as high as 30%. And then I know a number of you are working in rural communities. And we know that in rural settings, the incidence of IPV may be as high as 50% during the perinatal period. And I want to show you a little bit of a snapshot of what happened in COVID, okay? Because we know that child maltreatment reporting is down by 50%. We also know that intimate partner violence is up by nearly 10. So this was data taken from March 16th of 2020 through May of 2020. We know that there was, many of the callers, most of the callers had experienced emotional abuse, 61% had also experienced physical abuse, 24% experienced economic abuse, and 16% experienced technological abuse. So somebody going through your phone, using power and control to monitor your chat, to monitor your computer, et cetera. Here are some of the things that survivors said on those calls. The caller said they could not file paperwork to remove the abuser from their home because courts are closed due to COVID-19. A chatter mentioned that the abuser was using the virus as a scare tactic to keep the survivor away from their kids. A caller was experiencing an escalation of abuse. They had tested positive for COVID-19, and the abuser was using isolation to keep them from contacting families. So we see how COVID is this perfect petri dish for just that much more oversight and power and control than there has been before, because folks were working from home, folks lost their jobs, et cetera. So I want to go back for 1 second to that high rate of IPV among rural folks. So this is statewide data from Maine. And I think that it's going to resonate because I think the numbers will look very similar within your program. So many of you have required screening tools that you use for DV. Some of you don't, some of you do. But in this case, I want to show you examples of data for when they did have structured screening tools that needed to be done at certain intervals during the visits. So we see in 2018, 96% of moms being served in their program got screened for DV. So really high percentage. But if you look down below, look at the disclosure rate. Only 3% said, yes, this is happening to me, which really doesn't fit with the national data, right? What's going on here? So part of what today's journey is to look at the reasons why people can't tell us their stories. And you all have a lot of experience with why people can't tell us their stories. So we're going to highlight that, and then we're going to talk about our intervention moving forward. But before we get there, I want to hear from you all in the chat. Why do you think a person would stay in an abusive relationship? What are the reasons? I'd love to hear from y'all in the chat if you could. What are some reasons? Fear. Being alone is scary. Absolutely. What else? Finances shame kids, limited support system, love. Thank you for saying that one. Financial stress. Think the person will change. And sometimes they do. So fair. I want to talk about a reason that wasn't mentioned. And this is something, if there's one thing you're going to take away from today, and there's a lot of things I care about in the slide deck, but this is the one that's most important for you to put in your heart and hold. I think a lot of us who come to healthcare want to help people. And we think that the answer might be in an abusive relationship, leaving, right? Leaving a relationship can never, ever be the goal, because leaving comes with the highest likelihood of homicide or acute victimization. Sometimes the reason people stay is that is the absolute safest choice they can make, right? So part of what we want to do in our work around, thinking about bias and thinking about ways we can frame things through the lens of the other in front of us as opposed to our own frame, is to think about, to change our thinking from why hasn't the survivor left to what can I do to support this mom with what she needs? So again, thank you for that. I really want you to hold on to that one. I also think that unpacking this thing about I'm a successful provider if the client leaves needs to also be addressed, because if we stop making that part of the goal at all, then really you're supporting the mom is the best possible outcome. So thanks for listening while I reframed that. So I'm going to put you all in a room because you've been listening to me and there's a whole lot of wisdom on this call. So Alice is going to drop you into a Zoom room with like 5 or 6 folks. And I would love one person, if you could, to be our, in a Word doc, if you could just type the smart things people say, because I'm going to ask you, how does domestic impact women's perinatal health and their birth outcomes? Okay, so I want to hear what came up in your discussions. What wisdom do you have? Because I don't want to repeat stuff that you all already know. So how does domestic violence impact women's perinatal health and their birth outcomes?
So I have the chat from my group, and I'll put that in the chat.
Okay, great. Thank you. So Wesley, did you put it in the chat?
Not yet. That was someone else.
Okay, great.
I'm doing it now.
So I'm going to go ahead and just mention something that Tara Miller shared right before we went to the Zoom room. And she says, I'm with a nurse family partnership. One of my clients did not even know that she was in a verbally, emotionally isolated, physically abusive situation due to her childhood. She thought her relationship was normal until we did Power Wheels. And, really our intervention, Tara, really builds on what that Power Wheel has. It just adds sort of additional pieces to it. But we really think that universal education about what is a healthy relationship, what do people deserve, giving words to that. Again, you only know what you know, right? So sometimes somebody just talking about love and kindness and respect and being listened to is huge. So thank you for sharing that. And I see now there's 5 messages. So let me see. I'm going to back up here. Okay, so miscarriage, chronic stress, preterm and low birth weights, more incidence of negative health conditions for moms and babies, preterm birth, difficulty with attachment. Thank you for that. Lack of a support system because part of abuse is isolation. Absolutely. Potential challenges with breastfeeding, and we'll talk about that actually a little bit more. Nervous system, access to care, risk of suicide, lack of bonding, controlling the individual to the point that they do not attend a medical appointment. So it's what I'm just going to hold on to that one for a second because it's a delicious nugget. And it's not in my slide deck, but it's something I think it might be some version of that. But I think that's so important because the way we enter into wherever we're receiving care matters so much. So, I mean, as somebody who ran a clinic and had to sort of grab receptionists sometimes to say, the person that's missed the most appointments is the person you need to be nicest to because we don't know their story. And this might be their only time of being able to get out into the world was today. So we want to say, oh my gosh, it's so good to see you, not judge the fact that they've missed those appointments. And so it's such a lovely way to kind of put things on their heads. Stress can cause stillbirth. In my field tends to lead with untreated STIs that have an impact on the health of the baby. Thank you for saying that. So I'm gonna only hover in places where you all didn't share your wisdom. I didn't hear these things covered because I don't want to repeat. You covered a lot of these, but kidney infection, urinary tract infection, which could be connected to those STIs also. High blood pressure. We see vaginal bleeding because maybe there's injury to the abdomen. You mentioned suicide. I didn't see homicide, and I'm going to guess that folks don't know about this data necessarily, right? So we know that 45% of pregnancy-associated homicides were domestic violence associated, and that 53% of pregnancy-associated suicides involved intimate partner conflict attributable to the suicide. So that's a huge thing for your maternal morbidity groups to be thinking about, you know, as you're kind of gathering case notes, et cetera. I mean, that's sort of how this gets populated. So it's really important that your maternal death review committees are sort of, they're welcome to have all of this stuff. And I think sometimes it can be helpful. We talked about these things, low birth weight. I didn't hear so much necessarily around substance use or depression. I heard some about stress, so lower self-esteem. And then remember how I said, you know, Futures really takes this public health approach to intimate partner violence or domestic violence. So this is data from the National Domestic Violence Hotline. I do want you to know there was over 3,000 folks interviewed. And I want you to know those 3,000 folks were not in acute crisis. So these were questions only asked if someone was calling for support or they weren't in some kind of crisis situation. But what's interesting about this is you can see how power translates, right? So 26% ever used substances to reduce the pain of partner abuse. 27% were pressured or forced to use alcohol or drugs more than they wanted to by that abusive partner. Nearly 25% were afraid to call the police because they had their partner said they wouldn't believe you because you're using. 15% tried to get help for substance use. And here's the kicker. If they were trying to get help for substance use, the partner or ex-partner, 60% of the time, the partner or ex-partner tried to prevent or discourage them from getting help. So part of how power and control works is connected to substance use, right? So if you're trying to get sober and I want you to stay with me and not feel like you have other options, I'm going to bring, you know, that bottle and drop it on the table, or I'm going to, you know, engage you in some sort of way. And you can see here that about 38% experience a partner and ex-partner threatening to report alcohol or drug use to someone in authority to keep you from getting something you wanted or needed. I tell this story because, you know, having had the honor to do work with survivors for more than 20 years, I think that the stories that people share with me are something, if that can help other people think about patients differently, then it's a story that I want to make sure I share, because it's something that I hold in my heart. And it was a growth moment for me. And so those growth moments can be awkward. I'm actually having one right now. I'm going to tell you my growth moment. So you can imagine that when we're talking about research, and we're talking about research on birth, we are pretty focused on birthing mothers. This is not to say that we don't recognize that there are trans folks who also give birth. It's a function of how the stats are set up, but I want to apologize for not having birthing people in my slides. It's something that I'm working on, and to sort of make this feel like it's something for everyone. So I'm just going to acknowledge that. And this story is another sort of humble pie story. And I was doing research in Redding, California, which is a rural community. And they had one community health center. Everybody went to the community health center. Everybody knows everybody in this little town. And I was there doing research on intimate partner violence and its impact. So this is a long time ago, when there was no electronic health records. Everything was paper. So this person's it was three huge charts all connected to each other. That's how often this person came in for care. They had chronic pulmonary disorder, a whole lot of other things, and they were a 3-pack-a-day smoker. And if you opened up the chart, every single entry said the same thing, which is referred to kick the butts, referred to kick the butts, referred to kick the butts. Kick the Butts is a free smoking cessation program in California. So that makes sense, right? So I had an expectation when I sat down with this woman. Because she had smoked so much, she looked much older than she was. Her voice was really raspy, craggy, and she kind of had a certain kind of posture when she sat down. And I was like, oh, wow, this is going to be hard, and she's going to be tough. And I'm reading her exterior, forgetting that there was an interior. And I simply asked the question, so I'm here doing research. I understand that you had historically been in this abusive relationship with your ex-husband, and I'm just here to understand about, do you think that it impacts your smoking in any way? And that woman that I had sized up fully in front of me, her voice cracked. And she said, you don't understand. I couldn't pick up my phone, drive my car, see my parents, go to the store. I couldn't do anything without permission. The only thing I could do was smoke. And in that moment, I realized that it was her only friend. So I tell you that story. I'm sorry, I'm crying. But I tell you that story because it was a moment for me to realize that, wow, as woke as I want to think I am, as I've been doing this work for a while. But when I caught myself in that moment, I realized how much more I needed to grow. And it's so easy to judge people when they use substances and when they smoke during pregnancy. It's a thing that I've heard over and over again all across the country. But here's what we know about the data. And this is a place to hold this in your heart that's very different. we know that 42% of women experiencing some form of intimate partner violence could not stop smoking during pregnancy, compared to 15% of non-abused women. So that need to sort of, you're holding on, and the cigarette is the only thing kind of keeping you sane in that moment. It's the only friend you have. What a different way to approach a positive talk screen. What a different way to approach the issue of smoking. So sometimes when clients are smoking during pregnancy, I always wonder about how things are going in their relationship. Because I know if things are hard, if things are complicated, if you fight a lot, if you feeling uncomfortable, that all can affect you. It just really changes the way you hold it, I think. Y'all mentioned breastfeeding. It's not a surprise. Women experiencing physical abuse were more likely to cease breastfeeding. And I think sometimes, partners can be possessive of breasts and feel like that's something for them as opposed to something for the baby. It's an issue. And so if you've got somebody who is ceasing or not wanting to start, that's an interesting frame to hold it. If you've got a mom that has persistent postpartum depression, please wonder if that might be connected to the relationship, right? So women with controlling or threatening partners were 5 times more likely, that's a lot, to experience persistent symptoms of maternal depression. You mentioned missing appointments, not starting care until their 3rd trimester. So late entry to care is another tip off for you all to be thinking about in your clinical assessments. Maybe you knew this, maybe you didn't, but several studies have documented an association between poor weight gain and IPV during pregnancy. And then lastly, rapid repeat pregnancy, unintended pregnancy. We know that male partners' desires for or against pregnancy may overpower women's reproductive decisions. In this slide deck, because we don't have enough time to cover everything, we don't cover the issue of reproductive coercion. So when a partner is actively preventing you from using birth control or messing with your birth control, one of the strategies that we share with providers, because if you've got an abusive partner who wants you to become pregnant and you don't want to be, a harm reduction strategy is this. A copper T IUD allows you to still get your period at the same time every month. Many of the other methods, like if you use a Mirena IUD or you're using Implanon, sometimes that can make your period go away altogether. So what our strategy is if this is what a client wanted, if they told us that they weren't able to negotiate this with their partner, or their partner wanted them to be pregnant and they didn't want to be and they needed help, we had providers place IUDs and then cut the strings off so the partner couldn't feel it. And that gave them time, right? So they didn't have to deal with an unintended pregnancy on top of the already abusive relationship, and the partner didn't know. The other thing that we did was emergency contraceptives. We always recommend providers give double doses. We suggest if there's reproductive coercion involved, that you think about putting it in an envelope or out of that great big Plan B packaging that you see that, neon lights go off. So other strategies to sort of keep that more hidden. So we aren't going to go into depth there, but I just, because of who all you are, I just wanted to mention it here. All right. So in this moment where we collectively as a country are thinking about institutional racism, we are thinking and noticing the massive disparities and massive inequities, redlining, like voter suppression, like the list goes on, right? Within maternal care, we know that there's more to do. And so this is really dedicated to all the great work that's already been done and toward really this healing-centered engagement work, right? Where we see ourselves as part of the whole that we're looking to heal. We remember that it's not about us and them, the other over there, it's about all of us. And it's about really thinking about what does equity actually mean and how can it show up in meaningful ways in our work. So one thing I want to know, and this is just for you personally, okay? So I'm not going to ask you to say anything in the chat, but I just want you to take a little temperature check inside yourself. How comfortable are you right now with a domestic violence disclosure? Are you in the blue? You're really comfortable. You got this. You've done it before. You've got a good relationship with your local DV program. You know, you're comfortable with helping your client think about what strategies are they using to be safer. Great. Maybe you're in the middle. Maybe you're kind of in the greenish, yellowish area. You're like, I feel okay. Or maybe you're in the red, right? So in the please, oh, please, oh, please, oh, please, 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 don't disclose. So notice that, because I'm hoping at the end of today, you're going to move either from the red to the green, or from the light blue to the dark blue, or from the dark blue to the even darker blue that didn't exist on that curve. So to get us started thinking deeply about the people we serve, I want to start with you. So how many of you have personally, or know someone who has, ever left something out of a medical history or intentionally misreported information to their healthcare provider? I'm going to guess all of you, right? My question for you to answer in the chat is why? Why don't people tell us their stories? Why do they leave something out? Why do they intentionally misreport information? Thank you for that. Okay. Shame, shame, fear, feel guilty, scared, afraid a report will be made, stigma, embarrassed. Good. Have had bad experiences in the past with healthcare providers, have had experience in the past with reporting. You know, and if we think about it, somebody did mention it, but what's a mom's greatest fear? Child welfare involvement. You know, so that's an awfully good reason to go back to thinking about that data in Maine and why, in a state where more than half of the folks served are in rural communities. I mean, like, it takes 2 hours to get there kind of communities. Why folks only 3% disclosed. And what you've started doing here is unpacking the why. And we have some rights that we need to, righting of the boat that we need to consider together. Here's my nurse family partnership friend. You know, this is data from your program. If mandatory reporting were not an issue, she'd tell the nurse everything about the abuse. I say no when my home visitor asks me about abuse, because that's how you play the game. People are afraid of social services. That's my biggest fear. Like I was saying about my friend, the reason she don't disclose is because she thinks the nurse is going to call children's services, so she avoids the nurse a lot. And then this is a nurse from the Nurse Family Partnership that was being interviewed. We now have this thing where the police are calling children's services. Well, that prevents the mom from calling the police now, because she becomes the victim twice. Not only have I been hit, but now you might take my children away because he hit me. And so it goes. Something that looked like it was going to work goes in the other direction. All right, so we're in this moment, right? We are all thinking about, what does 911 mean in Black and Brown communities? What do we have a responsibility to be thinking about as healthcare providers relative to this very real issue that affects so many people? I can guarantee you many of your clients would never think to call that number. So we got to come up with better community strategies, build on the supports that exist. So health equity. Health equity means social justice in health, right? So that means that nobody's denied the possibility to be healthy for belonging to a group that has historically been economically or socially disadvantaged. It means that everyone has fair and a just opportunity to be as healthy as possible. To achieve this, we have to remove the obstacles to health, like poverty, discrimination, deep power imbalances, and their consequences, including lack of access to good jobs, fair pay, quality education, housing, safe environments, and healthcare. You know, this is the package, right? This is the wholeness we all deserve. And this is a wholeness that is not happening. And I want to give you a case example in Illinois, because I think that the numbers tell you a story. And I'm going to tell you how to remedy some of this story. So I promise I'm not going to leave you in a hard place. But in Illinois, non-Hispanic Black women are 6 times as likely to die from pregnancy-related conditions as non-Hispanic white women are. Black women are about 3 times as likely to die within a year of pregnancy as women of any other race or ethnicity. Homicides accounted for 15% of all pregnancy-associated deaths for Black women. In contrast, homicide was a very rare cause of pregnancy-associated death for white women. In 2018, there was an article that ran in the New York Times that was a game changer for me personally. So I think when we do this work with our patients, it is personal work, right? We come to this work for a reason. So I think historically, it was very easy to think as you looked at data like this, for example, from Illinois, you're like, oh, well, really, this is about poverty. That's what this is really about, right? So, and that's why the numbers are so disparate, because we know that there are more poor Black folks in America than poor white folks in America, based on a percentage of population. So this was the article that blew the lid off that whole thinking, because what they had data around were women who were middle class, had access to healthcare, had good healthcare, had insurance, all those things. And you know what? Their numbers look awfully similar to poor Black women. So then we have a different thing that we have to look at, which is this, you know, the implicit bias that exists within healthcare providers, the racism that exists in medicine. So, Alice, I think we're not going to try this. That's what we agreed to, right? Because it's just too hard to make the video work. If you just wouldn't mind dropping it in the chat, though, so folks can watch it afterwards. I love this TED Talk. It's not very long. I'm going to suggest to you that you might want to watch it as a group, like with your colleagues, because I think it's something you want to discuss afterwards. But this woman's name is Zoila Perez, and she's a doula. Doulas, love doulas. She's a doula, and she's also someone who has really thought deeply about issues of the impact of racism, the impact of what to do about the health, the inequality and the high maternal death rates for Black and brown women in America. So she's talking about a solution in this video. So the front half is sort of laying out the case a little bit like I did. And then the second half is about, well, what do we do about this? And what works? So if you don't know about the JJ Way, Jenny Joseph is a nurse midwife in Orlando, Florida. And when you go to her clinic, it feels more like your auntie's living room than it does like a clinic. Like there's, you know, big comfy chairs. I think a lot of them are recliners. You are greeted with this warm, loving space. Oh my gosh, I'm so glad to see you. No one is ever late for an appointment, ever. So imagine that framework. I'm so glad to see you. Awesome, right? And then women are in charge of part of their healthcare. So they do their own P tests, right? They take their own weight. They are engaged in a process as opposed to something that's being moved. And the secret of that model is in part having brought folks from the community in who are mommies themselves, who reflect the population and are warm and caring, because it's the OBGYN that's expensive, right? The community health worker, it's not as expensive. And they have more time to build those relationships, to build safety, to build trust. So this is really how we build on trauma-informed practices, because we can say those words, trustworthy. We want to be a trustworthy environment. We want to have transparency in the work. We want to make people feel seen and heard. But how do you actually do that? Well, I think we need to rethink kind of the model, right? So what we know to be true about Jenny Joseph's caseload is that her babies are born term and her mommies don't die. And the same hospital where her babies are delivered and her mommies give birth, other OBGYNs from that community have folks that come and do birthing there as well. And you can see the stark difference in the outcomes. So there are things that we can do right now in real time, in this moment, right, with all of the power of the maternity world to make some changes that really make a difference. So I'm just going to encourage you to watch her. I think the other thing that we have really been taking on is this idea of screening for intimate partner violence and other social determinants of health. And who is that for? And what is that about? So if you think about it, right? So 96% of women in Maine, mothers in Maine, were screened for domestic violence using a tool, something like this. Have you ever been hit, kicked, slapped, or choked by a current or former partner? But Alice, I want you to think about this. If I was in your backyard and we were drinking some sweet tea together, and I was checking in with you because I knew you were having issues with John, can you imagine me saying over that sweet tea, the tea is delish, and I love the lemon, and you did mint and lemon. That's my favorite combination, which is actually true. And by the way, if you haven't ever tried a little cinnamon in there, it's something to think about. So we're sitting in the backyard. I'd say to Alice, hey, I just want to check in with you. How are things going? And I know things have been hard, right? I would never say, so Alice, I'm wondering if he's hit, kicked, slapped, or choked you within the last. That's not a relationship, right? So when we go back to this idea of what does trauma-informed look like in real time, I do not believe it looks like, have you been hit, kicked, slapped, or choked? I believe that Nurse Family Partnership has given us some direction on where to go. And I'm going to say this with a big caveat. I don't want any of you to lose your funding. So if you must screen as a part of your program, please know that I'm going to give you a way to soften that truth. But I feel like, you know, if I've got the microphone, I need to use it and say, the emperor has no clothes, people. Let's rethink this a little bit. So here's what we know. The use of structured screening tools like the one I just described to you does not promote disclosure or in-depth exploration of women's experiences of abuse. No surprise, women are more likely to discuss violence when we have non-structured, real conversations in the same way that we would have with our friends, right? Because that's what people want. To feel safe is to feel like you're somebody who's got their back, that you can have a real conversation with them. And, you know, I honestly, there's a surveillance element to screening tools that I think we need to also really think about and unpack. Okay, so I'm challenging the limits of disclosure-driven practice. Okay, so here's how this works right now in healthcare, because I ran clinics, I did it, I did the work. I even screened folks right back in the day. That's kind of how, that's what I knew to do then, right? So the way it works is this. I ask Alice to do this depression screen, or I ask Alice questions about intimate partner violence. And Alice says, oh, no, everything's fine with John. And oh, no, I'm not feeling depressed. So I say, okay, great, let's move on. So I'm putting up my hands like a fence like this because I have all this knowledge, right? I know about services. I know about where to get help. I know all these things. And I also know now, I didn't before, but I know now that people can't tell us their stories so often, especially the most marginalized among us. So we have to change it so that we take this down and we make it more equitable for everyone, because right now I have the power over the information because you didn't tell me your story. And that is messed up. So universal education provides an opportunity for clients to make connections between violence, health problems, and risk behaviors. And again, if you are currently required to screen, I'm going to recommend that you do our intervention first so that you can create that sense of transparency, that sense of trust. You can honor the fact this person can't tell you their story, and then you can ask your evidence-based required question that I hope in my lifetime to see go away, frankly. So here is our intervention. This would be in person in COVID, before COVID, right? So what we would do is give you this little card, and I'll show you what it looks like. It's, by the way, oh, I have one. I don't think I have that one exactly, but I have one here. So this is what it looks like. It's the size of a business card. We modeled it after the shoe cards from DD Advocate Friends. It has multiple panels that talk about multiple things. The idea behind this is we wanted to give you all prompts and tools to use in real time with your folks so that you can, and they have little headers so they can kind of make it easier for you. So, are you in a healthy relationship? Are you in an unhealthy relationship? We're actually in a process of doing a big change around language and whatever, because I think healthy has become kind of more of a stigmatizing word, like you're not being healthy. So we're changing some of our language to reflect that, but it gives you an example of kind of how this works. So it talks about healthy relationships. So how's it going? All moms deserve healthy relationships. Ask yourself, do you feel treated with respect and kindness, safe and supported? Does my partner support my decisions about when or if I want to have more kids, right? So it's a great tool to open up conversations and touch on things that, both to make the point about what you deserve, but also to touch on things that you might not otherwise have been able to talk about. So here's what CUES is. This is a mnemonic, right? So Q stands for C, confidentiality. We want to be having these conversations alone. We don't want to have a partner present because we know that might upset the partner. And then it's all about how you frame this thing, right? So I've started giving 2 of these cards to all of my moms. I do it because relationships can change. I always give you 2, so you have info on how to help a friend or a family member too. What happened in that moment? So you have the info on how to help a friend or a family member too. So think on that. And you open up the card, which I just have lost somehow, but you open up that card that I showed you. It talks about healthy and safe relationships, ones that aren't, and how they can affect your health and pregnancy. It connects things you might not otherwise see, like how substance use or depression can be connected to hard relationships. On the back are these awesome 24/7 text hotlines that have folks who really understand complicated relationships. That's the intervention. That's it. That's the magic sauce. Oh, Alice, look at you. Thank you. So what do you think happens when we frame it this way? I've started giving 2 of these cards to all of my moms in case it's an issue for you. Just drop it in the chat. What do you think happens when we frame it this way? Oh, people are loving normalizing. Thank you, Nicole. What else happens when we say, I've given you 2 so you can help friends and family, you empower them. You share your power, right? So all of a sudden, and I want you to think about this through the lens of somebody who's being told they're worthless, they're a terrible mother, nobody would ever want them, you're used to being treated like trash. Imagine if someone says to you, I think you're somebody who can help people. Wow, it's so cool. Such a very, very cool thing. So so the essence of CUES is healing-centered engagement, right? It's building relationships, which is what everybody's hungry for. It improves access to advocacy because all of a sudden, if you hold up your little card again, Alice, all of a sudden, every single one of your clients has the domestic violence hotline number, has information on safety planning without having to tell you any of their business. And who among us doesn't know somebody who needed help, right? I mean, maybe my family's unusual, but I grew up in a very abusive home. All of my father's brothers and sisters also grew up in their abusive childhood home. They all had huge problems in their adult lives. So I grew up in this system of people who hurt people or were being hurt by people. So we all know folks, right? In our professional lives, in our personal lives. It's strength-based and caring-focused. It empowers clients and the folks they care about. It focuses on altruism. So here's the great thing, and I'm going to read this little quote to you at the bottom. The power of social support is more about mutuality, more about this, right, than about getting for yourself. There is a need to give, to matter, to make a difference. We find meaning in contributing to the well-being of others. That's not just true for you as healthcare providers, it's true for your clients. And that giving, sort of sharing that power with them and saying, you're somebody who can make a difference, I guarantee you that makes them feel good. Here's some of the research behind this cues intervention. These are interviews that I had the honor to do, so I know this. I know this provider's voice. It's in my head. The card made me feel empowered because you can really help somebody that might have been afraid to say anything or didn't know how to approach the topic. This is the door for them to open so they can feel more relaxed about talking about it. And here's what clients said. They would bring out the card, basically walk in with it, and she would open it and ask me if I'd ever seen it before. It was awesome. She would touch on no matter what the situation you're in, there's something or place that can help you. I don't have to be alone in it. That was really huge for me because I was alone most of the time for the worst part. We have stories of clients who got this card maybe a year in advance, like during their pregnancy, for example, or at the beginning of their home visitation, and they held on to it 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 and they held on to it. And a year in, shared with their provider, do you remember, I've kept this all this time and I want to share something with you. I'm out of that relationship now, but I held on to this because it helped me bridge that time. Okay, disclosure is not the goal, but disclosures do happen. And I want you to be prepared for them because I want you to feel comfortable and confident in how to do this. And I promise we're going to pivot in just a minute to talk about how do I do this if I can't see the person and they're not in front of me. So we're going to talk about the pivot to virtual cues, but I really wanted you to understand this thinking and the research because I really think it has a lot of use for when we do come back in person. So what do we know clients want? They want us to be non-judgmental. They want us to listen. They want us to offer information and support, and they don't want us to push for disclosure. So if we actually listen to the people that we serve and we hear these words and we heed them, they're telling us something. They don't want you to push for disclosure. They made their own case for why I don't want to be screened, but I like it when people talk to me about things so I have more information to make my own decisions. We would play the empathy video right now. If you don't know it, it's a good one. It's Brene Brown, and she talks about the difference between empathy and sympathy. So Alice, I'm gonna let you put that in the chat too, because I think it's a lovely, very short video, but it talks about the difference between being with someone and empathizing with someone and sympathizing with someone. Oh, wow, that's going on for you. Wow, that's a lot. She talks about trying to silver lining, sugarcoat things that are hard. And what she ends up coming with at the end of the video is saying, what do people actually want? Gosh, I'm so glad you shared that with me. I don't even know what to say. So one-line scripts. I'm glad you told me you're not alone. Help is available. So your recognition and validation of the situation are invaluable. Domestic violence advocates are the experts. And my gosh, I hope that you all have a memorandum of understanding with each and every, one in your vicinity so that you can really have them to support you because you deserve support. So one of the things I want to encourage you to do relative to your local program or the hotline is call them up and say, hi, I'm a healthcare provider from Baton Rouge. And I want to know if my client calls you, how does that look? How does that work? What will you do? How do you make them feel, safe and comfortable or whatever? Well, tell me what your spiel is. And when providers take that extra step, or, we're in Zoom right now, invite some GV folks over to do a virtual brown bag lunch so that they can talk about the services that they have available. Because as I mentioned, leaving can't be the goal. Totally might be the safest thing for that person to stay in place. But maybe there's some more services or supports that are available. Maybe they have a Wednesday night support group and you can come virtually, or they know about where to go to get something like that. Maybe there's a program that helps kids who've been exposed. Maybe they can help you with developing a resume, getting outfits if jobs are if the financial reality is a big part of what's going on and keeping you in that relationship. So there's a lot of pieces and strategies out there that can really help your clients. You know, as I think about COVID, Alice, especially, you know, and I mentioned the numbers before, we know it was at least a 10% increase. And I actually worry it was much bigger than that, because I think there's so much control happening with phones right now. I don't know who's able to get through, right? It could be completely unsafe for them to connect with anyone. So, so what we did with COVID is we said, okay, we've got to change this up. And what we recommended to healthcare providers across the board is please, please, please stop screening in COVID on Zoom, because you have no friggin' idea who's overhearing that conversation, and you have no idea how unsafe that might be for the person that you're doing it with. So the thing that you're doing to fix things or to check in on things is the very thing that could really hurt somebody. So we have to do this differently. So that's what this is about, is sort of recognizing that the C in Qs, which stands for confidentiality, is not something possible in Zoom. So supporting clients. What are virtual cues? It's a combination of things. It's scripts and texts, and Alice has a protocol for you that we're gonna give to you, and it has some sample scripts and texts in it. So y'all are gonna be able to play with it and try it on and have it available to you to use in however it works best for you. So it's, the idea is that, and forgive me, because the protocol is very, it was developed for home visitation, but it absolutely can be used in any maternity care, period, end of story. It's not unique to home visitation. The scripts would work in any OB setting, with any nurse, with any social worker. And I want to say that the scripts are intended to be put into your own voice, right? So these are my scripts, and I would change that script, frankly. If I had a 15-year-old sitting in front of me, I sound really different than I do if there's a 50-year-old in front of me. So, you know, all the magic sauce that you have about connecting and your authentic self and all that stuff, like, these are just meant to support you in conversations that can be hard to get started, or, you know, find a place to get started with them. So virtual cues, sharing positive support messages with clients during this challenging COVID-19 time, normalizing feelings, offering suggestions for ongoing support for ourselves and others. It's also, I'll give you some other scripts that are more specific about opening the door for conversations about healthy relationships and support for complicated relationships, or relationships where folks are being hurt. I think this is a great script for anybody, period, in COVID and beyond, right? So, hey, you know, this is really important strategy around helping the client be the one in control of their confidentiality, or their desire for other people to know about what's going on for them. So, hey, I just want to mention, I know while we're talking, folks may walk into the room, or you may not feel like continuing our conversation for whatever reason. If you are ever uncomfortable, change the subject and I will follow your lead. I don't care whether it's about birth control, substance use, IPV. This is a great framework, period, right? So, and again, to give the client power in a situation, and not continue down your path because you're the provider, but you're saying, you know what, you get to drive this train, and if this train isn't working for you, you let me know and I'll get on your train, right? So I think that's just a really helpful framework. I think someone went into the chat. I just want to make sure. All right, so here's some other strategies. These are examples of the scripts to find out who's in the room, or just get a read of the room. So tell me about who's going to be joining us today on the call. And again, some of you are probably doing this right now, but I just wanted to give folks tools in case they didn't have them. The house sounds quiet. Are you on your own today? I can't remember if Dad is joining us today, or if today is one of his work days. Is there any chance you can take yourself out for a walk while we talk? If not, no worries. Sometimes it's just nice to have one-on-one talk so we can focus on each other. So these are all little strategies to kind of get a better read on the room that I think can be really helpful, and were developed with maternity care folks. So these are their words and the strategies that they used. Here's an example of a script, right? I know with COVID, it's a hard time for all of us. Gotta normalize it. I mean, like, who are you not talking to on the, like, when I call my mom, I'm like, Mom, did you get your shot? Did you? How, how's it going? We're all doing that check-in about COVID. So the stress can be overwhelming, right? We're all worried about how we're going to feed our families, pay bills, everyone's on top of each other in the house, or maybe you're super lonely because you're living alone, right? And you're dealing with this pregnancy all on your own, all by yourself without supports. How's it been for you, right? So you want to acknowledge what you hear and mirror back what the client says. Again, this is a script to sort of get you started. You may have a perfect script and not need anything like this, but I just wanted to, support you all wherever you are. Okay, universal education about DV and parenting. Because of the stress, we're asking all of our moms to share this text that I'm about to send to you. It has information about additional supports in COVID that folks might not be aware of. That helps community support. It helps build more community support. 211 is a 24/7 confidential resource that has everything from food banks to info on substance use, mental health, childcare, parenting supports, and help for folks experiencing stress in their relationship, including increased fighting or harm that can affect health and parenting. That's it. Why did we do 211? What the heck is that, and what is that about? It is a national number. It connects, the operator can directly connect you to the domestic violence hotline number. When COVID began, we actually had the DV hotline number, on the bottom of the text that we would send out to them. And because I was doing deep work in the state of Maine, I found out from a home visitor that the partner who was looking through the phone saw that, clicked the link, went to the DV hotline and got mad at the home visitor and the client. So we stopped. We said, okay, we have to stop. This is a safety issue. We can't do this. 211 was the best option we had to be a cover, right? And you can call 211 after this and do the same thing I told you to do with the hotline. Check in with them. Say, hey, if my client called and they said, oh my gosh, I'm having a hard time in my relationship, what would you say to them? What would you do? And sure enough, they connect them to the DV hotline. It's also a website. So 211.org is the other place you can send folks. So here's an example of the sample text. You can take a picture of this with your smartphone and send it, or you can, maybe this is too wordy for you, or maybe you cut it down by half. Great. You just want to make sure you're kind of covering the bases, right? Quick thought for you in COVID, saying hopeful things out loud can help us with stress, which is true. Helping others can help us feel better too, so pass it along. So same framework around altruism, around saying, I think you have inherent value. I think you're someone who can make a difference for other people. All that same magic sauce is here. So you can see what it says on this text. 211 is a free confidential referral helpline that connects people of all ages from all communities to the essential health and human services they need 24/7. And it gives you the list. Here is an example of a more relationship-focused text, helping with relationship stress in COVID, share with others. How are things going for you at home? Relationships are stressed, parenting is hard, we all need support now more than ever. Isn't that true for all of us? I do. Are you feeling supported by the important people in your life? Are you being listened to, cared for, respected? Are parenting and pregnancy decisions supported? All great questions. Connecting with people can help us heal. If you or somebody you know needs additional supports for complicated relationships, call 211. You want to only share this text if the client says they want the DV hotline, because I told you we'd had these bad outcomes in the past that we want to avoid. So this is also a script for you. My friends who are nervous about, oh my God, I'm going to get a disclosure of DV and I don't know what to do. This is a very helpful framework for you not to make a misstep, right? So think about the power of someone you care about, your home visitor, your nurse, your social worker, your clinician. You're the one in charge of your life and you get to decide what to do. Like, thank you for telling me would be the first part. And then you're the one in charge of your life and you get to decide what you do next. I want to support you with what's most important to you. I'm here if you want to text or chat. If that's not true, then obviously you wouldn't say that line, but I think for some case managers and home visitors, there's more flexibility. I appreciate you, you're resourceful, and here's the hotline. But this idea, I really want to stop all of us from getting into our, I need to put on a cape and save you mode, because this person has been surviving and figuring out what works, what helps them. They are the expert of themselves. And I think, and their own lives. And I think that's just a really, and that takes some pressure off of you as the provider, because gosh, you've got a lot of expertise. That person is the absolute expert in themselves. So I think it's really helpful for you to describe what's available to them, talk about the local resources, which is why I want you to connect with them, tell them what happens when you call the DV hotline, make it a warm referral. But this is a sample text or a script for you to use if you do get a disclosure, so you know kind of where to go with that. There are confidential services I can help connect you to. I can make a three-way call. This is a very important intervention for y'all to know, okay? So if you have a smartphone and you got a client and you say, hey, so Alice has shared with me that this is going on in her life. And I'll say, oh my gosh, Alice, thank you for sharing that. You know, I really want you to know I respect your decisions and I really want to understand how I can best help you. One thing you might not know about that could be helpful for you is I can actually do a three-way call from my phone to an expert who can help us think through safer planning. And that way it won't show up on your phone. So we can stay on the call together if you'd like. I could stay on the call with you, introduce you, and then that way nobody knows that you made that call, right? So there's a lot of power in the three-way call, if that makes sense. So hi, I'm Shannon. I'm a home visitor. I have a client with me on the line who is in a complicated relationship. You're always going to use their words. So if your client says abusive relationship, if your client says mean, if your client's whatever word they use, you use word. You pair it back to them. I think it's really important for us to not label, right? So domestic violence is a big label. And I think we want to meet clients exactly where they are. And maybe they can look at one thread of a relationship, but you know, you gave me all of this wisdom on the phone or on the training earlier when I asked you about why do people stay, and you said love, hope for change. All of those things are also in there, right, in that mix. So you want to honor the person by listening to where they are in real time. Okay, so I'm going to stop here. Where are we in terms of time? We've got 40 minutes, Alice, is that right? I want to ask, so Alice is going to drop in those scripts for you into the chat, and we're going to give you a chance to sort of, as a group, read through those scripts. The first couple pages are about getting started or whatever. Skip those first couple pages, and you're going to go to where the scripts start, and you'll see those sample texts. So it'll be really easy to find in the document, if that makes sense. Those little pictures of the emojis on them and whatever. So I want to know now, though, questions on virtual queues, questions on the strategy, thoughts, concerns. I just want to open it up before I send you off to talk about it. I want to make sure that I've answered whatever questions I need to answer. Is it clear? Does it make sense? I think there are things in the chat, so I'm going to look in the chat, but feel free to unmute yourselves. Any questions for me, or should we just go ahead and drop you into a chat room so you can start looking at this document? Let me pull up again. I'm going to stop the share and I'm going to share something else with y'all. I stopped sharing my screen, right, Alice?
Right.
Okay, so I'm going to close that. I just wanted to show you all where to go in the document. But now I think I've done something wrong. Okay, wait. So let's see here.
I can pull it up if you need, Rebecca.
Share screen, Q's national program. Okay. Can y'all see this now? So, of course, now I can't make it work. Let's see here.
Oh, at page 4. Okay.
Yeah, so the document, right, it says Q's home visitation protocol, and we're just going to skip. It's like the thinking behind it, the overview, the implementing part. Don't worry about that, because I first want you to understand the scripts. So these are the confidentiality messages about, you know, seeing who's in the room, the universal education script, #1, and the sample text is here. And here's another one, another sample text. And so what I want you to do is look at those and see how you change them. You know, so look at those, tweak them for yourself, because I'm going to have you try it on. But I want you to have scripts that you feel good about. And also look at the sample text, and that you have it both formatted. So you can see here's the cute text that you can take a picture of and send off or put in Zoom chat. Or you can modify what the text says and make it your own. We just want to make sure we're covering that complicated relationship and offering 211, normalizing the situation. Okay, so are folks ready to kind of look at those scripts, try on what you do, you know, rewrite it for yourself, talk about it with your colleagues? Like, what do you think about this texting idea? I'm sure you're already doing crazy great things with text now. Maybe you have an innovation that you want me to know about, that you had an idea about, oh, this is what I would do, or this is how I handle that. Great, I want to hear that too. So if there's no other questions, I'm going to let folks go into breakout rooms. So going once, any questions?
I have a question, Rebecca, that somebody sent to me. They may have meant to send to everybody, but when you were saying text, do you have a recommendation for, like, if you send someone a text on their phone, or if you have a messaging as part of your whatever platform you're using for a video visit?
So you could do it on your phone. You could, if you're doing a Zoom call, you could drop it in the chat there for them to get. I mean, kind of whatever the platform, whatever's possible. If you've got a client who doesn't have a smartphone, because I know some of your folks only have flip phones, you might just want to text them that 211 number for help in COVID, right? So 211 is something, share it with your friends. This is awesome. You know, however, I realize there's limits and different scenarios allow for different things. So using your technology to do as much as you can with this is the goal. How's that? Okay, anything else? Anything else? Okay, so go ahead and drop them into rooms, Alice. Work on your, look at those scripts, change them. Think about the texts. What do you think about the approach in COVID to help families? Everybody's very quiet, or you're typing voraciously. It could be that. But please do feel free to mute. And it includes, like, it didn't work for me, it doesn't make sense to me, I don't like it. You can unmute yourself and say that too if you want to. I'm really open.
Just wanted to share that the 211 and all the different services they provide, and using that as a cover, as you mentioned, I thought was really thoughtful and considerate. Again, because we also know that one issue may be compounded by other issues. So, you know, lack of food security may, you know, have other ramifications. So having that 211 inform the reader that there are multiple services that could be offered, could empower both that person and offer assistance to others. So thank you for that.
Oh, no, thank you. And I think, let's just do this in reality. You're talking about intersecting things, right? So yes, I'm experiencing domestic violence and I don't have enough food to feed my kids tonight. So I'm going for the food conversation first. Do you know what I mean? And then, but it's allowing me to choose what do I need right now versus, so I have this vision for after COVID that we build out 211's capacity. And because I want you to think about this. This is another big thing I'm thinking about anyway. What does it mean to pick up a phone and call the domestic violence hotline? That's big. That means that I am saying something when I choose to make that phone call. And I think too about folks that use harm, and maybe sometimes they use harm, and maybe sometimes they are harmed. And where do you go if you're using harm? Where do you go to get support to address that behavior? If you know that you want to make some changes, right? Where do you go to have more support? You're going to call the domestic violence, you know what I mean? So there's just a lot in this moment to think about. So I appreciate y'all thinking with me. I think somebody said something in the chat, Chelsea. I think the scripted allows an opening to be tailored to my practice, and using 211 is such a good idea. It lets me do whatever I want to do when I want to do it. Yay, good. Okay, so I'm not hearing anybody else come off mic, but I'll do it one more time. Any other questions people have or scenarios that you were hoping that I might be able to address on the webinar today? And just feel free to sort of raise your hand if you'd like. We see virtual queues as a lifeline. We make sure that every client has knowledge about where to seek help for domestic violence. In this case, it's 211. If they disclose and they say they want more help and they say it's safe to give them, great, you can give them the National DV hotline. I want you to think about how cool it would be to include in your scripts, like 211 can help with all these things. And they also are connected to all of these other national support lines. If suicide is an issue, you can do a lot of education without naming the DV hotline. Your action may save lives. So I've been thinking about the big picture of maternal health on equity, innovation, and partnerships. What we talked about on Wednesday was this idea of reflective practice for all, that's something you all deserve, even the supervisors and managers on this call. We are hoping to see it expand, because one of the things we know about the workforce right now is that COVID has ground us all down to a nub. And we need to create more spaces and more capacity for people to feel held. Just like with our clients, we deserve to be held. I think we want to, we're really encouraging systems to think about how they use any additional funding they've gotten in COVID to celebrate, to make meaningful connections. We talked yesterday about sending out Laura Vandernoot Lipsky's book to folks as a thank you. I think it's really exciting to think about a CQI process, the continued quality improvement process, looking at staff wellness and growth and support, using RFP processes to create meaningful change. So if you are someone who has access to creating an RFP in the state of Illinois, I would love for you to say, in order for you to get this RFP, you need to create an MOU with you and your domestic violence agency, because we take this issue so seriously. So these are ways we've seen people in positions of power use it to broaden the supports for the workforce, but also for the clients they serve. Again, MOUs between home visitation, OBGYN, pediatric medical home, DV agencies, go big. One thing to also think about, and I know this is part of what Alice and Wesley are doing today, like I know this particular webinar cuts across different programs, which is awesome. doing more of that at the local level, I think can also save money and bandwidth, and everybody doesn't have to do their child welfare training. If people have access, they can do more of this, which I know this project is intended to support. Thinking about the JJ way and centering pregnancy is another model that really changes where the power structure sits. That's shown to make a big difference. So that's another resource for you to look at. Rethink using Zoom to rethink the mentoring process. One of the good things that I've heard come out of COVID is, if I'm a nurse in Illinois and there's a nurse in Alabama, because of Zoom, one of them can, if they're trying to learn something, or maybe this nurse has more skills around using those scripts, they can shadow in Zoom in ways that they couldn't before. So we've seen mentoring really take on a very cool space that I'm hoping we can hold on to in COVID. I hope that makes sense. Let's see here. So there were a couple things in the chat. I don't know if that's Alice.
Yeah, there's a request if you could put up the slide with the 211 info again. I think the script or the text that you suggested.
Absolutely.
Is 211 available in every state?
It is.
Awesome.
It is. That's why it's so exciting. So it's funded by the United Way. And in some states, they've doubled down. So this is like a little tickler for you. In some states, they've really expanded the capacity. So for example, all 211 operators in some states have been trained as domestic violence advocates. That's the standard. I would love that to be the standard for all programs. Some are really robust, some are very, small. It just depends. This is where I would say, I don't know what it looks like in your state. I know what it looks like in mine in California. I know in Alaska, what happens is sometimes you have to leave messages and but they do call you back, right? So just that connection, I think is just really lovely. And also there's the 211.org gives you access to big picture 211. So there's really a lot of support built into that as well. Is this what the chatter wanted, Alice? Is this the one? Or is it this one?
They just said the 211 info. So Tony, can you let us know? And we will send out the slides too.
Great.
This one, yep, this is the one.
Okay, good. And one thing here, I can, you can also do a little screenshot of it if you want. Put it in your phone that way. Okay, so I'm gonna go back here just a sec. You will have access to all of these slides immediately after the webinar, I believe, Alice, right? You're gonna send them out or soon thereafter. So I wanna just go back one more time to self-care. One thing that we've heard helps people be a little bit more, not so attached to all their devices around work, is turn off email when I'm not working on it, especially the sound. So you're not getting pinged constantly, but you can be more focused that way. Tell coworkers you're doing this, ask if they can connect with you via text if it's urgent. Schedule meetings that were 60 minutes long to 50 minutes. So let's say, we're gonna meet from 1 to 2, but actually you're gonna end the meeting at 1:50 so that you actually build in time to take a break. It's a really great strategy. I know a lot of programs have been using. Start meetings with deep breathing. In 50-minute meetings, take a 1 or 2 minute stretch break every 25 minutes. I don't think I practiced what I preached there, so sorry about that. I should have done a little bit more mindful movement today. I know you all have questions about where can I get those cards. So here's how you do that. So health@futureswithoutviolence.org. There's our phone number, the TTY number. And I really want to say this is like this much of all the things that we have available to you. So because for nonprofit and the National Health Resource Center, you know, we create, you might have to pay postage, but we create, you know, all kinds of tools, all kinds of things that are downloadable, posters, I mean, you name it. Model, sample MOUs is there. So you don't have to create one. You can modify what we have to make it really easy for you. So we are, unless there's questions, and I'm happy to take them, I think this is my, my goodbye. And my thanks to all of you for what you do every single day and for being open to this amazing time in history where we can make enormous changes together. So thank you.